So hello, my name is Olivia. Thank you very much for having me tonight. I'm going to talk to you about my elective in the Philippines, and I'd like to start by saying a massive thank you to everybody for the bursary, because it really helped me out and it was one of the best experiences of my life, and that made it possible. So I'm going to start by talking about the hospital. I went to the Western Visayas Medical Centre and I spent 6 weeks here. This was a government tertiary hospital and it covered 20,000 square kilometre region. I'm going to talk a bit about my learning outcomes that I set myself, about the areas within the hospital that I spent time in, and just a bit of reflection really on the whole experience. Which one was it?
It did work once I clicked on the computer and then it worked on the thing.
Yes, it needs to be woken up. It's not my fault. You just go forwards one.
Oh yes, yeah. There we go. So my main learning objective was to learn about healthcare in a different country, in a developing country, and primarily focus on the differences between that and the United Kingdom, what we're used to in the NHS. I wanted to see how low resources might impact that, and also learn a little bit about the Filipino culture. So I spent 2 weeks in the internal medicine department and 4 weeks in the surgical department, and I'm going to start by talking to you about my time in internal medicine. So this photo is from the Elective company who I went with information guide. They took it with consent, and I wanted to include it just to show the conditions in the ward. This was the hospital that I was in, and all of the wards were like this. And some things to mention about this, you can't see in the photo, but it's 35 to 40 degrees in the Philippines and there's no air conditioning. Some of the patients were lucky enough to have fans, but they weren't enough for every patient. There was about a metre or less between each patient's bed. There were stray cats walking around the wards and the smell wasn't the best at times. You can imagine that infection control was far from what we're used to. In the photo, you can see there's two people towards the left-hand side in the yellow shirts, and these are actually patients' family members. So in the Philippines, a family member can stay with the patient, and this is called a bante, and it's actually expected that the family member does this. There's no healthcare assistance in the Philippines, so this family member is responsible for all of the patient's personal care and also some of the nursing care, such as administering medication and helping with cleaning. I spoke to a few of the doctors because since COVID, these bantes come to the hospital with the patient. They do a PCR test, which has to be negative. And then once they're in, they're not allowed to leave the hospital at all. If they leave the hospital, they have to do another PCR, isolate until the results come, which can take a few days. And that in that time, the patient has nobody to help with their personal care. So I asked about what does these people do for their jobs? What do they do for their own commitments? And I was told that in the Philippines, family comes before everything. It's normal for people to lose jobs because of this, because they value family over anything. They can get another job, but they can't get more family. I do think bantes is quite a nice thing because the patient always had a familiar face, but it was also quite upsetting to see because the bantes didn't have beds themselves. They would sleep on flattened cardboard boxes on the floor, and it made the wards a lot more crowded when it was already very busy. So I spent some time in ICU and emergency department, and I just want to talk a bit about a couple of the presentations I saw there. So in the ICU, there were 5 beds, and 3 of these 5 beds had stroke patients in. The main difference from the UK with these stroke patients is that they were all in their 30s. This is really common in the Philippines. Some reasons for that is because there's a lot of uncontrolled hypertension. There's no primary prevention schemes in place. The Filipino diet's very high in sugar and salt. And also alcohol is very cheaper than food in some cases. So there's a lot of alcoholism there. In the emergency department, the equipment was quite old fashioned, as you can see in the ECG photo in the middle. Those blue clips would go around a patient's ankle and a nurse would use a paste pot to paste the strips onto an A4 paper for the doctor to look at. And on the right, I'm not sure if you can see, but there's an ECG that shows a STEMI. This patient had been having chest pain for 2 weeks and had been having this for 2 weeks. A lot of patients presented very late to the hospital. And this is because, as I said at the beginning, it covers a 20,000 square kilometres region. It's actually the only tertiary non-refusal hospital there in this region. Philippines has a highly privatised hospital network. So those who can afford to use that do. And the patients using this were the poorest patients who are having to travel over 10 hours, some by boats. A lot of them don't have private vehicles, and a lot of the roads weren't roads, they were mud tracks with like landslides, floods. So it was very difficult for patients to get to the hospital. There's no ambulance or 999 system. The ambulances that they do have is for the private hospitals, and the doctors go out in the ambulances themselves to see the patients. Also, a lot of the patients are scared of the hospital and the conditions because, as you saw in the last slide, they're not the nicest place to spend time. So I'm now going to talk about my surgical placement. Here are a few of the areas where I rotated around. I was lucky that I got to see a range of different areas. And I've just included these 3 photos because there's some areas in them that really highlight differences in acute surgical care between the Philippines and the UK. So the picture on the left is the treatment trolley for the orthopaedics outpatient clinic. So around the corner from where this picture's taken, there's 6 doctors seeing patients with or without appointments. And there's no sort of curtains, no separate rooms because they're just not available. So there's no privacy, everything's seen and heard. And if a patient needs any treatment, they come around this corner in the eye shot of some patients, in the earshot of all the other patients, to have their treatment done. And to give you an idea of the sort of things they do on this trolley, there was a patient who was coming in with suspected osteonecrosis of the finger, and they were planning to do an amputation here on that chair next to the trolley. Luckily for the patient, he didn't end up needing it. In the middle is a picture of the patient's entrance to the emergency department, and if you look closely, you can see that there's an X-ray machine in the middle. There was no lead available, there was no separate rooms available, so X-rays were done in a room with 40 patients, all sat less than a metre apart. In this same room, there was minor treatments. I saw a patient have his dorsalis pedis artery, which had been lacerated by machinery, ligated in the waiting room, whilst other patients covered their eyes and blocked their ears. There's also an incubator in that waiting room for any infants with illnesses, with no separate A&E for children. Finally, on the right is a picture of the anaesthesia machine, and I'm just going to sum this up with a quote from the anaesthetist who was explaining the conditions to me. And he said that we have his anaesthesia machine in Britain as well, but here it's in a museum. So in theatre, the conditions were actually a lot better than I expected. Here, sterility, there was a real effort made with infection control. I was expecting the gowns and drapes to be reusable because of the limited resources. What I wasn't expecting is that a lot of the equipment was reusable, including eye-gel airways, which will be used 5 times, whereas in the UK we dispose of them. Another thing that was very surprising for me is I was watching some neurosurgery, and as the surgeon was doing a craniotomy with a drill, he said, "Oh, I got this one off eBay." And I thought he was joking, but no. The hospital provides the most basic equipment, so they provide hand drills for craniotomies. If the surgeon wants anything else, they buy it themselves out of the pocket. And they do this because it reduces operating time and also really improves patient outcomes. So all of the equipment that they use in the surgery, other than the very basic stuff, they were buying themselves. And on the right, I just wanted to include the Philippines is a really religious country. I think 85% of the population is Catholic. So every member of the team would stop and read this prayer before every single procedure, which I just thought was really nice because it would give the patient and the family comfort to know that people were praying for them before. Finally, I just want to talk a bit about after placement. We got to spend some time at the local youth centre in the San Rafael community. So the children would live in this community on the right, and we got to play a lot of sports with them. We played basketball and volleyball, which are their local sports. And we took them some nutritional drinks and snacks, and we taught them how to play touch rugby as well, which went down very well. And I got a chance to travel on the weekend as well. There's some photos of that on the side. But yeah, thank you very much for listening. Does anybody have any questions?
Did you enjoy your time there?
Oh, I loved it, yes.
Yeah.
It's brilliant.
It looks something fantastic.
Yeah.
The actual work as well was.
Yeah, it was sad at times, obviously, because it's very different from what we're used to, but all of the staff, I can say, is some of the best medical staff I've ever worked with. The ward rounds, it was all junior led, it was people 1 year out of medical school, and they were doing the ward round from memory, which everyone was lovely, everyone was so welcoming. And although it was very sad to see the conditions, it was nice to see how they made the best out of the situation that they were in.
Think there's anything that you learned from there that you can bring back to thinking about?
Yeah, I've just realised I meant to repeat the question. So the question was, is there anything that I could learn that I could bring back? I think it was limited because the actual medicine was very similar and the treatments were the same, and when they were given, they were the same. As I said, it was privatised, so a lot of the times not every treatment was given because not every medication is given under the government hospital. So for example, some pain relief wasn't given, and it was just like the way they comforted the patients who didn't have the medications that they needed, and the way they worked around the bad situation was really good. But I think it was quite limited because it was just such a very different situation to what I'll ever work in here.
How did they maintain their morale?
I asked myself that a lot, to be honest. Sorry, so the question was, how did they maintain their morale? I think just the attitude that they have is that they do the best with what they have. I don't think I could go into work the way they did every day and maintain how happy they were, but at the same time they did acknowledge, you know, they did know that this isn't the best condition because the private hospitals are very similar to NHS hospitals. So a lot of the more senior doctors go and work in the private hospitals. They actually get paid a lot more for working in the government hospital, but they said it's not worth the money because of how stressful it is. But yeah, I'm not sure how they maintain the morale because I don't think I could stay that positive.
So you showed somebody who had an MI. How
Yes.
did they treat that? Were they able to sort of mobilise them, and as a result, did you get a lot of complications like heart failure and acute presentations of that?
So the question was that I showed somebody with an MI, how did they treat that, and were they able to thrombolyse it, and were there a lot of complications with it? So the treatment was exactly the same. Unfortunately, with that patient, he'd been having the MI for 2 weeks, so he was outside of the window. And there were a lot of patients with complications, not just from treatment that they were given, but a lot of patients were lost to follow-up during COVID. So in neurosurgery, there was a 4-year-old child who hadn't been seen in 2 years, and he had a lipomyelomeningocele at the bottom of his spine. This should have been routinely operated on when he was very early in his life, but because of COVID, he wasn't seen, and because people weren't allowed to travel to the hospital from the other regions. So this 4-year-old actually had cauda-equina syndrome because of the growth, because it had been left that long. So there were a lot of complications from the late treatment, but also from like delays in COVID because the COVID situation was still quite bad there.